The world's older population is growing at a rapid rate. As human beings grow old, their bodies wear out due to use, developing debilitating chronic conditions. Generally, people take more medications as they grow old. Nowadays, there is a pill for everything. Taking too many medications, or more than 4 medications, is called polypharmacy. This can become a problem. The more medications a person takes, the more chances of serious adverse reactions. That can lead to emergency visits. Or worse, hospital admissions. During clinic visits, the doctor might need to ask, does this patient really need all of these medications? It is always a little bit of a detective work to figure out which medications need to be eliminated or deprescribed. Our group decided to investigate which tool from the literature will best help our practitioners in the practice of deprescribing and management of polypharmacy, and conduct a practice change. We plan to implement the results of this evidence-based project in a community clinic in Arlington, Virginia, serving mostly older adults. Our burning desire to find the answer led us to formulate the clinical question. We learned that a well-formulated research question leads to a successful search strategy. We used PICO strategy to formulate our research question. This question is guided by PICO mnemonic, which is patient population, the older adults 65 and above who are receiving polypharmacy, the intervention, which is the polypharmacy management interventions, the comparison, lack of polypharmacy intervention, and the outcome, which is the reduction of adverse reactions. We used our PICO question to search different databases to evaluate which polypharmacy intervention is most effective. The answer to this question will be used to help our elderly patients in the clinic in the management of their medications. A review of publications indexed in the CINAHL, PubMed, Google Scholar, and Cochrane Library database was done for studies published from January 1, 2015, to 2021. And independent searches were also performed from other sources such as the American Geriatric Society. Our literature review yielded many results. In one study, the authors examined different criteria in same patients to determine medication appropriateness. In another study, medication appropriateness index showed 94%, stop criteria 57%, and Beers criteria 68% of patients were on medication contrary to their guideline. The Cochrane Systematic Review Analysis summarized related studies and pointed out advantages and limitations of each tool. After thorough literature review, we found that Beers criteria has been widely used and provides guidance for clinicians, patients, and health systems with specific drug recommendations for geriatric patients, especially in the domain of deprescribing and safe prescribing measures. Research supports our finding that the Beers criteria is beneficial in reducing inappropriate polypharmacy among older adults. Talking about goals, we want to keep it smart. Our specific goal is for healthcare providers and pharmacists to utilize 2019 Beers criteria to manage polypharmacy to decrease adverse effects, increase patients' medication compliance, and reduce hospital admissions. Our goal is measurable. We plan to retrieve 3 years of monthly data among patients older than 65 years old, with 4 or more medications and with history of hospital admission. These data will be compared to the data taken monthly after intervention. Our goal is attainable, realistic, and time-bound. To attain the goal, it is important to collaborate with other healthcare professionals to ensure medication appropriateness. We will begin with IRB approval on October 1, 2021. We will then initiate education to healthcare providers on November 1, 2021. We will measure outcome of intervention between December 1, 2021 to December 1, 2023. This is a realistic goal that gives us time to assess, educate, and monitor outcome of intervention. This shows the timeline of our evidence-based practice implementation. Phase 1 is pre-planning. Phase 2 is implementation. Phase 3 is data collection, and Phase 4 is synthesis and publication. We are hoping that our project will be successful. Because of that, we devised a plan to make it sustainable. We have identified 4 threats and devised a solution before it could hurt our project. In the beginning, pharmacists and healthcare providers will receive in-service training on the use of Beers criteria on the management of polypharmacy. The first threat is the possibility that project will not get started. The second threat is the challenges that healthcare providers have to keep up for this long project. The third threat is on the challenges educating patients using mail-order pharmacy. The fourth threat is patients' commitment. The solution that we identified is having a paid project RN who has the sole responsibility of doing in-service training to providers. The project RN will follow up, send email, and talk to providers, nurses and pharmacists. Call mail order services for any change in medication by providers, and educate patients through use of pamphlets, posters or consultations.